Yes, sir. Yes, sir. 50 years old male with intracapsular fracture of right femur, sir. With 2 years old CC screw injured in left, sir. Yes, sir. Right side again you get fracture, sir. Intracapsular, sir. Transfer. See. Yes, sir. See, we have done close reduction with internal fixation with CC screw, sir.
Twen- 21-year-old male with closed distal and radius fracture of right wrist with intra-articular extension. It's Freakman type 3 class. Ular button. Button, sir. Ular button. Ular button. Yes, sir. Due to intra-articular extension. Radius. Articular. We have done ORIF with plating for left radius with K wire. Here radial inclination, radial height, ulnar variance is also maintained and radial tilt also maintained.
This appears okay in the AP view. Okay, here you see where is the plate. This is the volar surface. Where is it going? This is what I anticipated. It is encroaching onto the joint.
Yes,
What will be there? What structures will be there? All the flexor tendons cross this. So constant movement of the wrist joint, flexion and extension, will cause pressure over the flexor tendons. Mores of the flexor pollicis longus. See here, this is where the flexor pollicis longus goes. These digitorum may escape, but the flexor pollicis longus is the one which will get. This man is going to have problem, and even he is likely to develop a median nerve palsy also. See, the almost nearly 7 to 8 mm is projecting beyond the distal articular margin of the radius. And after 3 or 4 months, he will come with rupture of the flexor pollicis longus. And at that time, repairing a ruptured flexor pollicis longus is a big job, and the results are not so good. Repair. That is why when you are fixing this, you have to look into the C-arm about the position of the plate. I advise this plate to be removed at the earliest before the patient develops a rupture of the flexor tendons. At the earliest, maybe after 4 weeks, when the fracture is likely to become sticky. When you are removing the K-wires, by that time fracture becomes sticky. Don't leave the plate for so long. Anyhow, you are going to immobilize this or start mobilizing the joint.
Immobilized.
What
sir.
is your...
Immobilized, sir, for
So the
4
purpose of fixation is partly defeated. When you are not mobilizing the joint, the purpose of the ORIF is partly defeated, 50%. What is the purpose of fixation of intra-articular fractures?
Early mobilization.
Anatomic reduction,
Articular
rigid fixation, and early mobilization. So the third part is gone when you are immobilized. You have to immobilize because you did not have a good purchase of the plate over the styloid area or whatever it is. So did you look into the C-arm when you are fixing
sir.
the plate?
Yes, sir. Yes, sir.
Then why it has gone so far distally? Definitely is going to have a problem with the tendon rupture. So follow up this case.
Okay.
And advise him to get the plate removed maybe after 6 weeks. At the time when you are removing the K-wire.
37-year-old female with closed distal fracture of left femur. It's Sensimer type 2A or AO Muller classification type A1.
These cases don't come to us. When they develop a complication, they go to some other doctors. Hand surgeons will deal these cases. So repairing a ruptured flexor pollicis longus is a very difficult proposition. You have to put a graft, and healing of the graft again is a problem. Okay.
These are the CD film. Supracondylar. We have done ORIF with plating for left femur. No, sir. Mipodic. Yes, sir.
Years-old female with closed tibial pad fracture of right knee, sir. Surgical type 2, sir. Lateral depression. Split and depression. These are the CT films, sir. We have done open reduction with plating for right TBS, sir. with bone elevators. Yes, sir. With bone elevator. Bone elevator. Yes, sir. Bone elevator. Yes, sir. Intact. Sir, bone punch. Joint. Raft. Further, sir. Repress. Yes, sir. To do tibia shaft and tibia. Yes, sir. Posterior, middle, posterior. CT. Middle, posterior. Yes, sir. Yes, sir. Yes, sir. Step off. 20 years old male with closed proximal third and distal third shaft fracture of left femur, sir. Winkiston and Anson characterization type 0, sir. We have done CRI with ILN for left femur, sir.
A 65-year-old female with closed partial tendinoacral tear of right angle. Actually, history of heel pain since 1 year, sir. 3 days old, sir. 3 days old, sir. These are the clinical pics. We have done tendinoacral repair with FHL transfer with interferon screw. Sir, to calcaneum. Detachment it calcaneum tuberosity. Attached to calcaneum. Flexor hansis. It yes, sir. No sir, detached. At heel level we detached. Sir, because of in introp when we open, it's of complete tear, sir, and fibrosis occurred. We debride the. Yes, sir. Yes, sir, crossing over. Yes, sir. Yes, sir. Actually, introp finding is complete tear, sir. That's what we. Yes, sir. Sir, it's insertional. 1 to 2 centimeters above ఉండే సార్. Yes, sir. Plantar is also we augmented. Yes, sir. We get more blood supply from FHL, sir, because of muscle belly to tendo Achilles to heel, sir. That's all. No, sir. No, sir. Yes, sir. Neutral, sir. Yes, sir. A slight equinus, plantar flexion of 5 to 10 degrees, we put a plaster. Yes.
Seventy-seven-year-old female with closed proximal third shaft fracture of the right femur. We've done open reduction internal fixation with long PFN and stainless steel wires. No, sir, we cut it after that. We cut while closing. Not the Siam. No, sir. We cut the wire, sir.
Yes, sir. Yes, sir.
77.
80% chance of non-union, because in both the views there is no contact at all, especially in the lateral view there is a fairly big gap.
We didn't open the fracture site. We tried closed reduction and
Here as you see the fracture is angulating, and there is an anterior angulation, and then it's not in the center of the medullary, because it is angulated. Here,
yes, sir.
what, instead of allowing the fracture, what I was suggesting is, instead of allowing this fracture to go into non-union and do a redo procedure, I am suggesting a small plate augmentation with primary bone grafting. The basic principle of primary bone grafting in a fracture fixation is with a significant comminution of more than 1/3 of the circumference.
Yes, sir.
This is the primary indication for bone graft. Though we think that this is a closed healing of a fracture because you are not open, the presence of significant comminution and macro motion. Abductors will pull this fragment outwards, the adductors will pull it inwards, thereby increasing the chance of angulation further in spite of the sacromedullary fixation. So this is the right case for plate augmentation and primary bone grafting.
Yes, sir.
In the first sitting itself, where the chances of union are almost 90%.
Yes, sir.
This is the case that can be kept in the conference. What are the cases where you can prevent revision surgery? This is our big. This is the right case. What is the reason we have to know why we are doing? Yeah, that's what. Two principles. The muscular forces, this is the primary deforming force, and also the comminution and macro motion. These are the key indications for primary plate augmentation. Is a standard, well accepted universally. That is the right procedure to be done in this case. And there, you need to open up only minimally. Now, if it goes into non-union, you have to redo the nail and excise all the fibrous tissue. You have to strip all the tissue here, and then they become relatively less vascular. And then again, you need to put quite a big amount of bone graft, and then chances of healing are very much delayed. I think this is the right case for this. Which cases can be prevented for a revision surgery? You put up this case.
Yes, sir.
No, and how to prevent revision surgeries. That also you can focus. To anticipate the problems, why they require a second surgery, and then how to prevent. I think this is an educative case.
Sir, tip apex system.
Notorious for non-union.
We don't want the screw to migrate into the joint space. Sir.
Because the hold of the screw will be in the subchondral bone.
Yes, sir.
That is why the concept of tip apex fixation comes. So even in PFN also you have to keep the screws up to subchondral bone.
Yes, sir.
Otherwise you are won't hold much.
The age of the patient is 52.
Yes, sir.
Relatively young. Yeah, wait. Yeah, wait. What is your suggestion for this case? Already discussed. He says that all intraarticular fractures should be anatomically reduced and ridiculous and stabilized early. Basic principles.
Slight palmar flexion. Yes, sir.
Recently, CSMS Prasad from Khammam, a neurosurgeon, he has treated done the plate fixation. This can be, I think, this can be treated reasonably very conservatively. Yeah, you may have to apply a very good snug fitting cost. Here should be complete information in your
Bank inflation was there or sinus was there?
distal screw infection is not a problem to be worried about. You just remove the screw and then leave the implant like that, and it still gives the stability.
लेकिन फुट जाता है, लेकिन फुट जाता है,
Firdaus photo and
फुट है,
Is there an infection along all along the nail? Go back to the implant. Is it an infected nail or only screw is infected? How do you judge? నేను కాదంటాం మళ్ళీ అదే ఉంది కేసు.
ये इनको lose or not?
Is there any lucency all along the length of the nail? No radial lucency. It means it is not infected. What Firdaus? Why did you give the job to him?
Sir, I was not there for 5 days, sir. I came to. It was not loose, sir. Only there was no pus inside the nail, sir. Just sign. No, sir. Only since 3 days he had some bleb and pus discharge was there, sir.
The screw might have become loose.
Loose.
It is causing irritation. Okay. This limb should be protected.
We have applied a
Lab will not do it. నా రోజు డ్రాప్ తీసేస్తారు. ఎయిర్ కాఫ్ స్టిచ్ చేస్తే it prevents angular mobility. And at nights you can remove it and keep the limb free.
sir, we advised cast after surgery.
కాస్ట్ కంటే సౌక్ అండి. ప్రీఓపీ కాస్ట్ ఎంత? ప్రీఓపీలు అవుతాయా? ప్రీఓపీలు అవుతాయా? వేసినందుకు ఛార్జెస్ అవుతాయా? వెంటనే ఛార్జెస్ అవుతాయి. Nowadays,
जाओ हो गया. 60-year female with grade 2 middle third both bone shaft fracture of right leg and bimalleolar fracture of right ankle, sir. We have done closed reduction internal fixation with island for right tibia and malleolar screw for medial malleolus and recon plate for fibula, sir.
is it a recon plate or a
Recon, sir.
recon?
Yes.
Ideally, the contour plate.
Contour plates.
Why not recon? Why not contour plate? Why recon? Here with recon, you will not be able to align the lateral malleolus angle to the shaft of the fibula of 15 degrees because we can't judge correctly. The pre-contoured plate will restore the lateral malleolus to the shaft 15 degrees angle. Otherwise, mortise will be crowded.
Zoom.
The ankle mortise will be crowded. It is almost in straight line. See the lateral malleolus. See the lateral malleolus and the shaft of the fibula are in the
Same line.
alignment. And there will be crowding of the mortise. Where is the mortise view?
Not this.
There is a routine.
Yes.
3 views for ankle. Okay. The recon plate can easily bend in the hand.
Yes.
Could have been bent a little bit here.
35-year male with closed transverse fracture of left patella, sir. We have done tension band wiring for patella, sir, left patella. It's communicated. Yes.
2 main fragments.
Yes.
2 main fragments.
Ideal indication. Transverse fracture. To get it together and yes, sir.
The insertion of the KYs should be at the junction of the anterior one-third and the posterior two-thirds
Yes.
of the width of the patella. Here it is almost stuck on the, of course it's not in the true lateral view, little oblique. Okay, next. Immobilized,
Yes, sir. Immobilized.
how long?
6 weeks.
The purpose of fixing is labor.
Lost us.
Last, total. You will come with a stiffening at the end of 6 weeks.
Move to allow movement. Yes. No, yes, sir.
When he starts flexing the knee,
Yes, sir.
the tension band is
Good morning, sir.
when you are flexing the knee, the tension band principle will compress these two fragments.
Yes.
That is the principle. If you immobilize it for 6 weeks, it will become a knee.
65-year female with intertrochanteric fracture of left femur, sir. We have done closed reduction with PFN for left femur. Thank you, sir.
Good morning, sir. These are the cases done Unit 2. 6-year-old male with proximal shaft fracture of left femur, sir. We have done CRIF with TENS for left femur. TENS.
How many years?
6 years old, sir. We can keep traction. We can go for hip spike also.
Go back.
Yes, sir.
Yeah, but in the bed long time.
It's
Probably
6 years old, so that's why.
acceptable. Close 20.
Yes, sir. Close, sir.
Snap fitting Thomas plane, fixed fracture.
That also will help. Community.
So cylindrical still.
Back slap or
Slabs, black.
It is adding to the burden of the distal fragment peak, and it is going to power much more arm than without a slab. Entire weight of the slab is acting at the distal fragment. Probably it can be treated with hip spike or
Hips. Yes.
radial.
Okay. 85-year-old male with intertrochanteric fracture of right femur. This is Boyden-Griffin type 2. We have done close reduction internal fixation with short PFN for right femur.
good reduction.
74-year-old female with subtrochanteric fracture of right femur, Boyden-Griffin type 3. We have done close reduction with long PFN for right femurs. 50-year-old male with intertrochanteric fracture of right femur. This Boyden-Griffin type 2. We have done CRIF with short PFN for right femurs. There is a 25-year-old male with grade 3B compound shaft fracture of 5th metatarsal of left foot, sir. We have done K-wire fixation with wound debridement for this.
Primary closure.
No, sir, just we have put one stay suture, sir. Then immediately we have done next day, we have posted the case and we have done.
In 6 hours you should do, you have to close.
Sir.
Whether close or
No.
not. Contaminated, it should leave them.
Okay. 36-year-old male with radial head dislocation with proximal third isolated ulnar fracture, sir. This Monteggia fracture. Ulnar fracture. So Bardos type 3, sir. Sir. Yes, sir, adult, sir. Type 3, sir. Because it's a lateral displacement of radial head.
Send this case to man. Okay. Jawahar. Go back. Right. Next one. So what's the problem?
This is a lateral open.
No, the X-ray you can read. Yes.
Not rested and laterally it is open. Medially it's open.
There is an angulation. The flexors are pulling it into flexion. The effectors in the plasma fragment APU is getting into effection. The distal fragment is very long. All the effector attachments. The constant muscular force is acting like a factor.
And there is still gap.
Gap is there.
Though there is overlap, but there is gap is there. There is no contact there. Yes, sir.
There is a significant combination with the gap, more so in the lateral group. There is no contact at all. And I suspect that it is likely to go into non-union, very high chances. So instead of leaving it like this with a unstable fixation, I am suggesting that a primary small anti-rotation plate and primary bone grafting to fill the gap.
How many days old this one?
So fresh.
In young adults, exclusion, case reports, reviews, meta-analysis, combined osteotomy procedures. Because there were two principles of treatment of non-vascular fibrillar graft with valgus osteotomy. Studies included qualitative synthesis, it's only 15. Qualitative, sir. Treatment strategy, reduction, close reduction is preferred, open reduction if close reduction is failed. Fixation, one fibrillar graft with two or three canceller screws. Alternative, dual graft in severe resorption or long delay cases. Rehabilitation, early non-weight bearing with gradual weight bearing after union. Adjunct valgus osteotomy in various hips with non-union. There's a cases done by them. X-ray of left hip, anteroposterior view showing a 30-year-old female with 6 months old femoral neck fracture. They have done fracture as united after non-vascular fibrillar graft osteosynthesis, and after 13 years of follow-up, the hip joint is still preserved with good functional outcome. This is done by Professor Nagi. There's the results. There was no uniformity in the evaluation of functional outcome. Various scores were used by the authors. Across studies, 60 to 96% of the patient achieved good to excellent outcomes, commonly measured by hip Harris scores, Nagi's or Larson's criteria. Many patients regained near normal range of motions. These are the studies done by different, sorry.
Go back.
Sir. Different surgeons.
All are from India.
Yes, sir. Mostly all. Nagi et al. He was 40 patients. 17% good to excellent result with Nagi score. In complications, head collapse, coxa fractures, shortening, and infection. Whereas Mishra, 25 patients, fairly satisfactory. Complications, osteonecrosis, graft failure, infection, collapse, donor morbidity. Complications, non-union rate in 12 out of 15 studies were less than 10%. Osteonecrosis, 13 of 15 reported osteonecrosis incidents, which range from 0 to 21% post-operatively. In 6 studies that documented pre- and post-operative status, fibular osteosynthesis showed improvement in osteonecrosis. There is a coxa deformity, limb shortening, intra-articular penetration of the graft or hardware. Conclusion, non-vascularized fibular graft is a reliable and simple technique for young adults in non-union or neglected femoral neck fractures, which leads to good functional recovery, minimal complications, and improvement in osteonecrosis. It is technically less demanding, preferred option in resource limited settings where vascular grafting is difficult. Criticism, there is a lack of uniformity in functional outcome scores across the studies. Some studies lack long-term follow-up data, mostly observational studies with limited randomized evidence. Dual grafting studies not conclusive for superiority. There is a case done in our hospitals. 20 years old female with 3 months old fractured neck of right femur. There is a 6 months follow-up.
Where is the hip X-ray?
Hip,
Post-op hip X-ray.
post-op I have got only once.
Only femur, right femur X-ray was taken?
Only have shown the right side, which is fractured now.
There.
Yes, sir. Yes. Only 6 months, sir.
When was it done?
No, in 16 now.
What happened after X-ray?
Stress I couldn't get.
Patient, did you speak to patient?
No, sir. From MRT I have tracked that. Yes, yes. 16.
X-ray.
So thanks.
Collect.
Okay, sir.
Must be there.
Yes, sir.
Won't get subjection there. You said, no contacts, you said, phone. ఈరోజు కూర్చుంది అమీర్
Yes, sir.
ఈ సిట్ డౌన్ మార్నింగ్ వెళ్ళి ఓకే ఓటీ ఎవరున్నారు ఈరోజు all the medical colleges, all contacts.
Almost colleges we have contacted, sir. All that and different people. Yes, sir.
Other people. I also called my, but if you will do it. Not message, speak to them.